I gotta confess something to you all, NextMed family. This is my first NextMed, and I've been having an absolute blast. For those of you who are catching the live stream at home, you gotta come next year. But I have to also confess this, there's this sort of subtext underneath all of the presentations and what I've seen in the Innovation Lab, this question of who gets access to all of this cool stuff? For the folks at home, we have a machine in the other room that creates a digital avatar of you. We have an app that allows you to check heart rate and respiratory rate by your phone. And just last night, I was in the middle of a Gloria Estefan song at karaoke last night. I was pulled out to go do a 10-minute HIIT workout with an Oculus Rift, and it was like the hardest workout I've ever done in my entire life, I have to say. But at the end of the day, what I'm left with is this question of who gets access to all this? We still live in a country where 20% of the population doesn't even have internet at their home. And if we're not careful, what we're going to do is widen the disparities. Now, there's a lot of facts and sort of figures for you here, but what I want to leave you with is a story, because I'm going to go back to the emergency room as soon as I get off that flight tomorrow, and I'm going to go into an overnight shift. And I want to give you a sense of what it feels like to be working in the ED nowadays. Just recently, I was taking care of a young woman who's in her early 20s, a Latina. She came in with abdominal pain, and she was there with her elderly father who had Parkinson's disease. She told me the story and, really couldn't get much out of what, her presenting illness was. So I did an exam and, tried to sort of rack my brain. What is going on with this woman? But for the clinicians in the room, you will know the feeling of just feeling like you're missing something from the story. So we decided to do a broader test. Does she have appendicitis? Does she have a UTI? Does she have a kidney stone? Is she pregnant? We got her labs back about an hour later. She had none of those things. She has something called starvation ketosis. You get starvation ketosis when you haven't eaten. This woman was in the ER with abdominal pain because she was hungry. I went back to talk to this young woman about her lab results. And I said, from what we've seen here, it looks like you're not eating. What's going on? And she told me, well, doc, I have, my dad with me here, and he's got Parkinson's and a bunch of other medical issues. And his co-pays are going up. And I have to make decisions about how we spend money in the house. Do I pay for his bills, his meds, or do I eat? This is the nature of the American healthcare system that we live in and that we work in today. And I promise you, when I go to that overnight shift on Thursday, I will hear stories just as bad. So as we create these innovations, these interventions, we must keep in mind this question: for whom do these innovations and interventions actually work? I have the pleasure of inviting to the stage an incredible group of, as I mentioned, troublemakers for good, who are going to talk a little bit more about the work that they do. And so come on up, join me, y'all. So we're going to start on my left here with Esther Dyson, who's an author, journalist, philanthropist, and also CEO of Wellville. Over to you, Esther.
Okay, great, it's working. So I'm not going to talk about Wellville other than to say it's a 10-year nonprofit project. We work with 5 communities around the US, and we don't give them money, we don't bribe them to do what we think they should do. We coach them as they do what they're going to do so that they own it. And there are really 2 missions to Wellville. One is for these 5 communities to build more social and medical infrastructure that they own that's sustainable. And the other mission was for our team, which is about 5 or 6 people, to learn enough and to make trouble. So I'm going to give a very brief explanation of the messages we're going to try and send out in the world, not as Wellville, but helping to foster much broader movements. They are: don't rent your health, defund healthcare, and a quadrant chart. Everybody needs a quadrant chart. The quadrant chart of addiction. And then it will be Lee's turn. So the first one, don't rent your health. Own it and invest in it. Health is an asset. People keep talking about healthcare, which is basically fixing that asset. But as you've heard already this morning, if you work with children and you keep them healthy, they've got this asset that makes them resilient to stress that, when you get COVID, if you're healthy, you're much better off. And the challenge is to see that as a long-term thing that you own. The way I thought about this originally was when I was in my apartment that I rented, had a plumbing problem. Plumber came, looked under the sink, pulled out this disgusting pipe and said, "Oh my gosh, look at this." And I said, "That's your job. I don't want to look at that." But that should not be the way we think about our bodies. And it also applies to don't rent your community's health. Second, defund healthcare. Not the care that brings health, but the paperwork, the predatory healthcare that keeps you stuck to a machine when really you should. We've all heard a lot about this for the last 3 or 4 days. It's like defunding the police. Take that money and spend it on the right things. In the case of the police, it's healthier neighborhoods, it's lighting, it's all the social fabric that keeps people with better things to do than to prey on their neighbors. And in health, it's the same. It's what you've heard about this morning. It's finding out which kids need help so they don't go into the NICU early. Helping mothers to know how to eat right, helping them have enough money to do that. As Tom said, price in the externalities, tax sugar, tax processed foods, and then put that money into subsidizing childcare, not child storage, which is what we see a lot of, but actual child care, child education. Put it into healthy foods, put it into cooking classes, and then, yes, people have challenges. Put it into mental health support, put it into trauma-informed care in schools, and build a healthier society so that we don't end up with this huge bill for having rented something for so long. And then finally, the thing that I really learned through the years of Wellville was what addiction really is. When people talked about being addicted to Facebook a few years ago, I thought, yes, that's a clever metaphor. And then I learned more. What addiction really is, it's not about the drugs or the alcohol or the substance. You can be addicted to food, you can be addicted to gambling or to something like Robinhood, which pretends to be investing but is actually gambling. You can be addicted, obviously, to Netflix, and the thing that makes addiction is the craving for relief from that craving. You get that very, very short-term relief, but it never lasts, and you just feel guilty. So, number one, it makes you very short-term. You have no sense of the future. You've kind of, if it gets really bad, you've kind of left your family. You're unmoored from your past and your history. But you're also unmoored from the things around you, from your family, from a job, from all the things that cross the community. So this is an experiment in audience participation, mostly because I was too busy to make a slide, but join me. Lower left-hand corner is, and I'm using this, some people find it offensive, the drug addict. Just needs another fix. Lost moorings in their community. Benevolent billionaire gives the drug addict $100. He's in the upper left-hand corner. The guy spends it on drugs. No surprise. But the billionaire actually feels good because he thinks he's done something. He hasn't. That same billionaire also gives $100 million to the medical school because he wants his wife to get good treatment in case anything goes wrong. And he also sends $100 million to Harvard because his son is applying. And so he's thinking long term. But he's not thinking about the community he lives in. He's not thinking, ironically, he's not even thinking about having good employees or living in a community that, anyway. So what we're trying to do is to get people to move up to that magical upper right-hand quadrant and think long-term about the entire community, whether it's where they live or the state, and this fits in so nicely with the voting thing. And I'll come back to that later.
Fantastic.
Thank you very much.
Thank you very much, Esther. And in case folks didn't see the audience participation plug at the top of the screen, we're taking questions. You can send your questions to me via Twitter DM. That's at Alister F. Martin on Twitter. I saw some of you already send questions in. So if there are things that are piquing your interest or things you want to dive deeper into, please send those questions on. I want to now transition to someone who's become a fast friend of mine, and I can tell we're going to be at this work for a long time together, Dr. Lee Sanders. Lee Sanders is a pediatrician first and foremost, and a professor of pediatrics and health policy at Stanford, as well as the chief of General Pediatrics. Over to you, Dr. Sanders.
Thank you. I want to start with GA. What is GA? I am full right now of gratitude, awe, and humility. And I just want to acknowledge that. I feel great gratitude toward Shauna and Daniel for inviting me and us up here. Incredible awe of my panelists here, whose work I've followed, and many of the people in this room. I mean, we started the day learning about how light and sound will heal us. Extraordinary work being done. And humility. I come to this with great humility despite my titles and 25 years of doing health equity research, in that I'm always learning, and just over the past few days have been learning so much from so many of you. But I hope through a brief couple stories I can leave all of you with some key messages that might be useful to the work that each of you do. I've been getting to know new people and old friends, and so that's the message here. So. As Alister mentioned, I am first and foremost a pediatrician, a general pediatrician. And for the better part of 25 years, I've been taking care of patients like Arya. With permission from her and her family. Arya here is a 4-year-old girl who was born preterm. She has intellectual disability, chronic lung disease, is fed through a tube. She was recently hospitalized for pneumonia. She has 4 chronic medications, 12 subspecialists, has been cared for in her first 4 years of life across 3 different health systems. Her mother has a chronic disease, her sister as well. She's a primary caregiver of her mother, single mom, low-wage worker, limited formal education, lives in East Palo Alto in a 1-bedroom apartment, multi-generational housing. For me, even though I'm at Stanford, I work at a community health center, take care of mainly patients on Medicaid. This is our average patient. A family like Arya, or a mother like Arya's mother, drew this map. We call it a care map. I encourage, for those of you clinicians, to ask your patients, particularly those with chronic illness, to draw this. And the question was, please draw a map of what it's like to care for your child. And what I like to point out to you, as well as my own students, is that, of course, we have the child in the center and the family, but the whole health system, everything that we've been talking about for the past few days, is only in that lower left-hand corner in blue, and includes oral health for our oral health folks. But the other quadrants of where this mother needs to navigate every day, every week, every year, are in the areas of the school system: advocacy and leadership, recreation and community, and social support. And I like this grounding and this privilege of caring for other people's children, because it drives the question that I wake up with every day, and that sometimes keeps me awake at night, which is, what sort of system do we need to meet everyone's health needs? Arya, her sister, her mother, in these very real constraints. I'm going to talk a little bit about social determinants of health, but oftentimes it's talked about at a geographic level. I mentioned I work at Stanford University, which is on the left-hand side of this screen, and if you're born within a mile or two of where I live, your life expectancy is greater than 80 years. But if you're born within a mile or two of where Arya lives, your life expectancy is less than 62 years. So I'm listening, I'm adding, and I'm attributing Shauna Butler this quote to you, that many health challenges are the result of failed policies. That's why we need to join forces with Alister and his group. And we do, I'm not just wearing this on the stage, we do wear these voter registration lanyards in our clinic up in the upper left-hand corner there in Redwood City, where we have a community health center. Now, how many of you here have heard that your zip code is more important than your genetic code in expressing your health outcomes? Okay, is Mike Snyder still in the audience? Because I'm sure he pushes against this. Well, I think this is too simplistic. This hard-to-read graph there is often published. It's a compendium that needs to be updated every year of a lot of observational data suggesting that in a purely correlational sense, yes, your social determinants, physical environment, social and policy circumstances, individual behavior, do explain more than 50% of important health outcomes: chronic disease, infant mortality, adult mortality. In contrast to the many biologic determinants, all the omics that Mike and Daniel and I are very excited about. And very importantly, much more than your healthcare determinants, medical care. But I have a mentor at Stanford, a very wise mentor named Paul Wise, if you ever meet him. And he's been really instructive in a different model of thinking about social determinants and health equity that I want to share with you. And it suggests that this is the wrong way to think about it, because it almost pits us against one another. Oh, you're working on omics, and I'm working on social determinants. That's not the way to think about it. In fact, when I ask people about health inequity, the intuition is that it's all about poor access. We were talking a lot this morning about getting access to rapid MRIs in distant places in sub-Saharan Africa and the global south. Well, that's part of it, but the real equation is 3 ingredients. It's not just poor access. It's poor access for high-risk populations to highly efficacious technology. And where we fail, and where we have repeatedly failed, and where the challenge for each of you is not to fail, is in creating efficacious technology that is not accessible to those who are at highest risk. Because when we do this, and we recurrently do this, including my own field, we create a health disparity overnight. I might talk later about the story of surfactant, which really cut and improved infant lives as an example of this. I do a lot of work. I direct a health literacy lab, and so I'm just going to use this as an instructive example. This is some of my data and word slides. That in the U.S. and globally, more than 1/3 of adults has below basic or basic literacy. They can't do many of the things in the bullets here: understand an appointment slip, interpret a growth chart, understand basic instructions on a medication bottle, even if it's well written. And that's a challenge, because we are continuously creating a more consumer-directed healthcare system. That's what all of us are doing here. And most of the information we're putting out there, most of the health websites, insurance forms, and so forth, with the exception of a few things, are written at a level too high for most individuals to understand. This is globally as well as in the U.S. My colleague at Johns Hopkins, Deborah Roeder, calls this public health malpractice, so I add this to the slide to wake people up. We would never do this with a medication, put something that's that much out of risk on an intentional and daily basis. So the challenge for us with this health equity model is to address this, to look at ways that we can reduce information complexity for those at lowest risk so that they can get greater access to the medications, procedures, VRs, diagnostics, everything that you guys are working on here. That's why I suggest we do. Because we're not doing this, this is a brief, we continuously do these systematic reviews, list of many of the health inequities that result from low health literacy and our failure to address this, so I won't go into that because I want to discuss this later. There are lots of lessons for precision health and product design and system design. I just want to end on one other quick story. I leapfrogged into the design school, the D school at Stanford, just about 5 years ago. on a lark after Burning Man. Ask me about Burning Man later. And I challenged 15 undergrads with this challenge: apply human-centered design to craft a system that operationalizes this model, improves access to efficacious health technology for everyone at risk. And we brought patients into the classroom, families from our own clinic as co-designers. So we exposed them to everything, including the fact that the fax machine is still driving things in the clinic, but the patients were at the center. They explained the problems. Some of the patients welcomed the families into their homes. They got to sit in David Kelly's truck and do journey maps and all of this. So I said, this is fun. I'm really enjoying the classroom experience. Thank you, Jules Sherman, my co-teacher, for getting me to do this. But what was the students' response? Nothing short of remarkable. After 25 years of taking care of patients, including many of the patients who came into there, they came up with key insights that all patients want. They want help with little things done at home, achieving non-medical goals, to be respected and validated, to be accepted as normal, to take a break. And they came up with designs that they didn't think they would come up with. These are Stanford students. They all want to create an app and make $1 billion, right? But their essential designs were brilliant. Village, a wedding registry for post-NICU support. Ben came up with ID tags for families caregivers to validate them. And they helped me redesign some of the things I've been working on for years. Reach Out and Read, which makes early literacy promotion as routine as now voting registration will be in primary care. Obesity prevention to attack what we heard earlier today about we are what we eat, and a virtual pharmacist for adolescents. So the key messages I want to leave you with is think about this broader model of health equity, improving access for the highest risk communities, particularly when you're developing highly efficacious technology, co-design with patients from high-risk communities with a health literacy lens, and join me in trying to practice humility more every day. So thank you.
That's right.
Thank you.
Thank you very much, Dr. Lee Sanders. I certainly will be following up to ask you about your experience at Burning Man. Although I feel like this is kind of like Burning Man for nerds, right? Or, no? Just another plug, please continue sending your messages in. We're getting them. If there are things that are piquing your interest, questions you have, places to go deeper, please send them in. I now have the pleasure of introducing Rajiv Ranonki, who is Vice President, Senior Vice President at Elevance and President at Carelon Digital. Over to you, Rajiv.
Thank you, Alister. And love the D-School idea, by the way. I think healthcare needs a Johnny Ive. And despite all of your humility, I think maybe that's the opportunity here, because that's, I think, the compelling part of what we can do. The lab over here was not impressed with your presentation. I think he's taking a nice nap over there, by the way. Those of you that haven't seen this dog, lovely little dog over here, come say hi. So hope you don't mind that. So long title, and the reason that we came up with that title was I was trying to break our Workday system, see what actually kind of breaks our HR systems. That was it. But the role that my team and myself play is that we are creating basically what we call a digital platform for health. And you asked the question, Alister, about, well, how does this wonderful innovation here that you saw in the innovation lab and everyone else that talked about it up here on the stage, how does it get into the hands of the consumers? So our platform, essentially think of it as the access to all of this innovation, but done so in a responsible manner. Make sure that if it's an AI solution, that it's got ethics and bias and all of those factors accounted for. If it's access, then how do we make it ubiquitously accessible, not just into the hands of the few? Like I said, many people in our country still don't have access to internet, and high-speed internet in particular. How do we account for that? So all those factors considered go into our platform, which essentially connects caregivers like yourself and Lee with the consumers that need that care, and personalize that interaction in every step possible, which is why the design points that you made are so critical. So my frame is here on 5 points, connecting some dots here, right? So one is around personalizing and engaging our consumers. And doing so by connecting all the dots, the community level, social, health, genomics, phenome, all of that together. But also digitizing and virtualizing care, and I'll get into why that's important in a second, and then connecting it back into care delivered at home, care delivered in the clinics, care delivered in hospitals, and everywhere else that care happens. And then finally, creating an interoperability layer as the foundation of exchanging data in healthcare, that puts consumers in charge of their data, the communities in charge of their data, and makes it ubiquitously accessible without sacrificing privacy or security of that data. So let's get into a little bit about how we're doing that. First up, why does engagement matter? We kind of flip what Esther said, right? So why does Netflix kind of serve up that watch this show if you watch this, or any of your favorite social media platforms like TikTok that continually kind of mine what your eyeballs are landing and for how long, and are serving up the next thing that you would want to watch. How about we, take the metaphor of trouble for good and flip that and say, how can we use it for good, the addiction for good, so that more healthcare content, more engagement leads to healthier lives and healthier communities. And the same algorithms probably could be repurposed to do exactly that. And so that's not a theory. That's many of the things that we're trying at Elevance Health is around personalizing and engaging for good and making good healthcare and good health outcomes addictive in a good way. To do that, then we have to connect all the dots. Of course, electronic medical records, claims data, labs data and all of that, but much more so on data beyond. What zip code? You said 60, less than 60 years in one zip code, and more than 80 in the Stanford area, for obvious reasons. But let's get underneath that. What's driving that? Is it access to transportation? Is it access to nutrition, parks? How is the community actually designed to reduce that disparity? And all that needs to get into our data so that we can actually inform policy, inform community, inform our activation mechanisms to make that happen. So that's another pillar of what we're doing. Digitizing and virtualizing care, there's probably a virtual and a digital health company in every corner of the healthcare system. Question is, how do we make that more personalized and engaging? And I'll just maybe use a simple analogy. While the underlying physical resource of healthcare with doctors and clinics, hospitals, care at home, that's always going to be the case. What we want to digitize and virtualize is the access to that. So think about it. So many of you probably came into the San Diego airport, called up a Lyft or an Uber, and got here knowing what the price is and the comfort of whatever X, Y, Z, black mode of transportation you chose. The resource there, the physical resource of the car and the driver, of course, are the same. Taxis are the same. But the access to that has been digitized and virtualized. Right? So more people have access to it. There's more transparency as to what resources is available when and how. And you're continually optimizing supply and demand so that more people can get access to it in a transparent way. Can that be done for healthcare? And if so, how can we personalize it at scale so that if I'm a Latinx consumer and I want Latinx primary care, I can get that. If I'm LGBTQ+, then what are my specific care needs that I can get access to? We don't have instrumentation of that. I can connect supply and demand and maybe make an appointment today, but how do I make that personalized connection? That's what we want to do with digitizing and virtualizing care. But that's not enough. That can't be a silo. It has to connect to care at home, has to connect care in the hospitals, care in the clinics, so that, Alister, the example you used of ketosis by starvation, we should be having leading indicators of that, so that all these community resources that are available perhaps could be made available via some channel to that person that says, okay, you don't have to make that trade-off. Perhaps you can get access to it without having to end up in the ER, thus costing the system 10x what it would have cost to just provide nutritious food in the first place, right? So to do all of that, we need sort of data to be connected at every point of the node of the network. And my personal premise is that the best way to get this done is to use a blockchain-based infrastructure to connect all the data dots across the country, and then design the system from that sort of foundation. Make sure that the consumers own their data, communities own their data, and let's activate that data through personalized engagement, making that data available ubiquitously to all the caregivers that need it, and ultimately putting it in the hands of all of the parts of the healthcare ecosystem to actually impact health outcomes and improve access and quality. So that's, in a nutshell, our strategy. Hopefully that's a blueprint for everything else that we're doing in the system. And again, thank you for having us here.
Love that. Thank you very much, Rajiv. And there's a lot of questions that are coming in that are about, well, how do we start? Right, we've got a good idea for an innovation or an intervention in the healthcare space. How do we model that and build it with the communities in mind at the beginning? So we're not doing this work of building a really cool innovation and then having to think about health equity retrospectively. Mm-hmm. how do we actually invite folks from these communities to the table to help us co-create the solutions? This idea that those closest to the problem are closest to the solutions. So I'm interested in all of you. How do you think about this idea of sort of co-creating with the communities in mind? Maybe you can start, Esther.
Yeah.
We'll go this way.
I mean, first of all, what we do, we actually work in the communities, and we're not mostly in the business of devices, though I'll talk about that in one moment. Sometimes you should go sit at their table instead of inviting them to yours, and it's hard. People don't schedule as effectively. That it's hard to get to places. You're dealing with people who do not. This usually is not their daytime job. Some community organizations, yes, but when you actually. Okay, my favorite story, Scranton, Dr. Feinberg came in from UCLA. It was wonderful. He surveyed, discovered that the community felt basically disrespected, and changed a lot of things, put in a your money back guarantee, which worked amazingly. And a bunch of the nice community philanthropists and so forth invited some community members to come to a big event where they were talking about community health, and they were smart. They didn't put the community up on the stage and sort of inspect them like a petting zoo. They said, let's just have lunch together. We'll mingle at the tables and listen to you. Guess what the community members brought with them? Their children, because they have no childcare. And it was a real eye-opener. So that you have to understand how inconvenient life is for many people. The other story I want to tell briefly is, long story, but I had this brilliant idea. I thought we should give some kids CGMs and let them understand not just their own metabolism.
Can you just describe what CGM is?
A continuous glucose monitor, so they can watch how their sugar reacts to stress, to food, to your parents arguing, which creates stress. And then we also were going to teach them about the metabolism of the food system, which is trying to make money by selling them bad food that's addictive. And a couple of things happened. First, rumor went around, Wellville is getting $1 million from a pharma company to stick pins in black kids' shoulders. Can that one. We went to Ura. And this is obviously a much longer story, but the person writing the IRB kept saying outcomes like children losing weight. And for many children, that's a good outcome. But what we finally changed it to is the outcome was a sense of agency. If you want to lose weight, you're going to learn how. But we're not coming in to tell you what you need to do. We're coming in to help you understand what you might want to do, because you understand better, again, the metabolism of the food system that's trying to manipulate you. The reality is this particular project is still stuck in the IRB process, and that's a learning too. We're doing much better with working directly with community organizations, getting childcare pulled up together between the YMCA and the Goodwill. The most important thing is help them collaborate. Don't dangle grants. Community organizations get addicted to short-term grants. Then they compete with one another, they hire expensive grant writers, and you end up creating more silos because these organizations are competing for your scarce dollars.
Yeah. And Lee, I think this comes back to a point that you were going to make earlier.
Yeah, I just want to echo and admire, Esther, what you said and what you're doing with Wellville, which is also staying with communities at high risk for 10 years and going back and being accountable. I don't want to lose that. That's sort of part of the. Listen, I gave you some of my points before. I'm a recovering academic, and what that means is that I have been doing this, the answer to this, for a long time under the heading of community-based participatory research. It's another acronym, CBPR, look it up. It works pretty well in public health research. What does that mean? Focus groups, key informant interviews, great. I think the design approach and the learned approach has taught me differently, and it echoes what Esther just said. Go to where people are. It's not them, it's us. So, if patients are coming in, make sure you're really attendant to the patients that are highest risk that are coming into your clinics. Sit and listen, and it takes time. Listen at school board. We go to school board meetings now, English second language schools, public health meetings. That might not apply to all of you, but just listen. Many health organizations, you might be talking about this, are starting to build out true, dynamic, community-based offices. So I agree. Go to where folks are and really, really listen. And the biggest challenge, I think, for all of us is to set aside our preconceived notions. Evan's a designer there. Jules has taught me this. Stacey Chang. You're looking for problems, not somebody to validate the solution you're putting down. And that is the hardest thing we need to do, to listen. And the problem might be really far afield from what the solution that you're proposing. So or we are proposing. That's part of the humility. I don't know what.
Great point. I think my good friend Maria, who's in the audience, used to be our chief innovation officer at Elevance Health, used to say, fall in love with the problem.
Yeah.
I think that's in some ways what you're saying, Lee. And I think the solutions will present themselves to that. So just a few ideas, just to riff on here. I think one, for the startups that are here in the audience and a part of this community, I think a lot of what we end up designing is on we call it an individual's identity. You create an asset, an app or a resource, you download the app, and you have to register as an individual. I think health is much more family-oriented, to Esther's point. Health is much more community-oriented. So rethinking identity from a community and a family and a caregiver perspective, I think, presents some super interesting options. Technically, it means that we have to understand privacy and security of data and organize around communities and families. And what it enables us to do is a few interesting things. So we ran a design challenge in a community a couple of years ago on, so how do we get kids and parents and grandparents more engaged in health outcomes? So one of the ideas that one of the kids came up with was, well, how about if we put a cheat code into a video game? And that cheat code was, well, you got to go, take a few thousand steps with the family, all of them. And then if you then validate that activity actually happened, we'll give you the cheat code to get to the next stage. In fact, we talked to a video game professor in UC Irvine, Constance, who's part of the faculty here, and I think she's actually looking at how that might actually get to market. Something that we would have never dreamed of, but as you activate the communities, there's lots of ideas like that come into play that are super interesting. And then I think the notion of scaling, because the cliche of healthcare being local is absolutely true, but then local solutions that are one-off don't scale. And the same solution in one community is not going to be applicable to another community. So the question is, how do we mass personalize that, and how do we have a scale in mind across the country? So to do that, our thought was, every community needs to have a community well-being index that measures the health of that community across various social and health and non-health factors. And then an individual has to have a health index, and a family perhaps has to have the same thing, so we can measure all those things and then look at kind of what factors are driving which outcomes, and then tailoring that continuously so that the entire health of the entire nation gets better.
I love that. And I think what you're hearing here is a through line, and that is to invoke the anthropologist within you. Right, a part of this is anthropology, going to the community. I love Esther's point. It's not about inviting the community to your table. It's about going to their table, picking up all kinds of nuance and detail there. We're going to enter into the last segment of our time together, and that is the Tweet This segment. All right? So we're going to go rapid fire, and we're going to have each of our panelists kind of close us out with, what's the tweetable? What are people gonna put on their socials that they're gonna take away from this? What would you, if you could sort of boil it down to less than 280 characters, what would that be? Why don't we go in reverse this time? Rajiv, over to you.
That's a tough one, Alister. Maybe I'd say, create sort of a new design for health that's based on access and equity.
Love that.
Love it. Maybe co-design for health equity with patients in your highest risk community.
Love it.
Don't rent your community's and parents' health. Own it and invest in it and share it.
And I'm going to add one that Lee Sanders reminded me of last night, and that is nothing about us without us. Thank you all very much.
And come see us invite them to 1:30, the breakout.
What's that?
Remind them of the breakout.
Oh, yeah, we're going to definitely go to a breakout later on, Cabana A, to continue these conversations and more. So we hope to see you there.